Hello and welcome back. Today we're going to be talking about the hospital or healthcare entity patient relationship. Also, we will mainly focus on EMTALA, or the Emergency Medical Treatment and Active Labor Act, and access to emergency care, as that is the main statute or law that impacts a hospital's duties to patients, or at least for access to emergency care. So it's a very important law and really sets the stage for how hospitals treat patients and access to care. So in general, a hospital's duty to provide care for patients is based on the hospital's state licensure, and states will have a licensure act, generally called the Hospital Licensure Act, that sets out all the requirements for being a hospital and sets out requirements that the hospital must meet. Those statutes are very specific. They prescribe how many square feet you have to have for rooms, for hallways, for stairwells, various types of requirements that hospitals are required to meet. But one of those things is that for a hospital to be licensed, it determines the number of beds a hospital has and so forth. Hospitals generally also, and particularly in this day and time, will receive accreditation from agencies. It's not a governmental agencies, but really from, different locations. But one, the most common one being the Joint Commission. It's an accrediting body. It is not a governmental body, but CMS and the state health departments often will look to a hospital's accreditation and the accreditation findings or survey findings to determine if the hospital is meeting the requirements that are generally required by that state or by CMS. So because of their licensure and their accreditation status, hospitals do receive often funding from public sources. Healthcare is extremely expensive, and most hospitals are not able to survive without some public funding. So they're often considered to be sort of quasi-public facilities or entities, even though there are many private hospitals. And in general, there's sort of three types of hospitals, and particularly when we're talking about acute care hospitals, but they are private, for-profit hospitals. Then the second category would be private nonprofit hospitals, and those hospitals have an obligation to provide a certain amount of charity care. And then there are the public hospitals, and the public hospitals generally are the largest providers of care to uninsured or to indigent patients. But almost all hospitals will accept federal funding, if nothing else in the form of Medicare, and then also state funding from Medicaid. And so anti-discrimination laws apply. And so a hospital cannot make decisions of patient access based on prohibitive classes such as age, race, religion, national origin, and so forth. So a hospital's relationship to its patients is fundamentally different than the physician-patient relationship. The physician doesn't have those quasi-public, or often may choose not to accept Medicare patients, so they won't have those same funding ties to providing care. But capacity to provide unfunded care or indigent care, care for uninsured patients, often stretches hospitals to the limits. And so beginning, I don't know when it began, but in the 1980s, something known as patient dumping became a major issue and a problem for healthcare or healthcare delivery system in the United States. And there were numerous empirical studies done that said the majority of patient transfers from one hospital to another, or of uninsured patients or of indigent patients, and the majority of patients are transferred to public hospitals. And the main reason for the transfer is not to provide the patient with a higher level of care, or care that the transferring hospital can't provide, but it's mainly because the patient that's being transferred can't pay for care. And one problem with that patient dumping was that the the issues continue to get worse and worse. So rather than stabilizing a patient and providing needed care and then transferring a patient when it's appropriate, many people would come there if they were unfunded or didn't have the ability to care. They would sit in the waiting rooms until the hospital could tell or determine that this patient doesn't have funding, they don't have any insurance, we're not going to get paid for their care. They would never provide them any treatment, and they would put them in an ambulance or send them on their way in their private car to go to another hospital, either a nonprofit hospital or more likely a public hospital. And that became known as patient dumping, because these patients would show up at the receiving hospital or the hospital that the patient was told to go to, and the patient would be in a life or death situation. They would not be stabilized. Many patients died during these patient dumping days. So that became a very big problem. One thing I want to do is to stop and let you watch. It's a very brief YouTube video that's called Before EMTALA, and it's an emergency physician's perspective on the patient dumping problem.